Now let's come to how to manage exacerbations of asthma and COPD. Let's first define what is an exacerbation. An exacerbation is a worsening in symptoms. It's a subjective finding by the patient. The patient is going to tell you, my symptoms are acutely getting worse. And here is a key word, acute worsening in symptoms. It's beyond the normal day-to-day fluctuation of baseline lung function. It's something that is more acute worsening of symptoms. What triggers exacerbation? In asthma, maybe allergen exposure, viral upper respiratory tract infection, air pollution, smoke, exercise, cold temperature, or pneumonia. In COPD, it is most of the time pneumonia. Most of the time is pneumonia. And sometimes even, interestingly, pulmonary embolism can be one of the triggers of exacerbation in COPD patients. The patient with asthma will experience subjective increase in his cough, shortness of breath, wheezing. The patient with COPD will experience subjective increase in his cough, shortness of breath, sputum. The physical findings are similar in both asthma and COPD exacerbations. You will get tachypnea, you will get tachycardia, you will get wheezing, you will get decreased breath sounds and use of accessory respiratory muscles, flaring of tonsils, of nostrils, speaking in short sentences, tripod position to help the patient breathe, cyanosis, and maybe altered mental status. Peak flow, this is the handy device that I told you that it assesses the severity of asthma exacerbation. We use this device in the ER or even at your office or maybe even at the patient's home to assess the severity of his airway obstruction. You instruct the patient how to use this. The patient is going to take a deep breath and he's going to make a tight mouth seal around the mouthpiece and exhale as strongly as possible, and he gets this red knob into a reading. The patient has to do this test 3 times on 3 separate days and takes his best result as his control. And then the patient is going to follow up this peak flow. And maybe there is another scale on the side where the patient can adjust this green yellow button to 80% of his best result and the yellow red button knob to the 50% of his best result. If the patient is always in the green zone, more than 80% of his control or his best result, this is a normal or a usually well-controlled patient. If the patient's peak flow acutely dropped into this yellow zone, which is between 50% and 80% of the patient's baseline, this is considered as moderate exacerbation of asthma. If the patient's symptoms acutely drop or the peak flow acutely dropped to this red zone, which is less than 50% of his baseline, this is severe exacerbation of asthma. We usually do not rely on the peak flow meter for COPD assessment, in assessment of COPD exacerbation. When to hospitalize? When to hospitalize? One important thing, severe respiratory distress with inadequate response to outpatient management. Inadequate response to outpatient management, altered mental status, worsening hypoxemia. Don't forget, acute respiratory acidosis is not just an indication for hospitalization, it's an indication for ICU admission and maybe also mechanical ventilation. How are we going to manage? For asthma, the sequence is, I'm going to start by SABA, albuterol. If it doesn't work alone, I'm going to add to it ipratropium. I'm going to give you Combivent. If it does not act, then I don't have any alternative, but let me try Maxalf intravenously for persistent threatening airway obstruction. It's not that Maxalf is stronger. Which is stronger, albuterol or Maxalf as a bronchodilator? Definitely it is albuterol. Then why are you giving me Maxalf? Because I do not have any other alternatives. I tried albuterol and it didn't work. Maybe when I try Maxalf after albuterol, maybe I can get some help. So albuterol, Combivent, magnesium sulfate, this is for your bronchospasm, and also I have to give you systemic steroids, whether oral prednisone, but for ICU patients we give intravenous methylprednisolone. Antibiotics are not routinely used for asthma exacerbation. We use them only if there is pneumonia. In COPD, I only have one drug to give you as a bronchodilator, Combivent, and that's it. And the steroids, the same, prednisone orally, methylprednisolone intravenously. What's new in COPD? I have to give you antibiotics. Azithromycin, fluoroquinolones, or if there is a risk of Pseudomonas infection, I give you piperacillin, tazobactam, Zosyn. And ventilatory support, there are definite indications for ventilation, when to use ventilation for asthma and COPD, but these are beyond the scope of this course. This is what antibiotics are you going to select for patients with COPD exacerbation. As I said, mild exacerbation with no risk factor of poor outcome, azithromycin is enough. Moderate exacerbation in COPD or moderate risk factors for poor outcome, use amoxiclav or ceftriaxone. If there is a severe exacerbation, severe risk factors for poor outcome, and risk factor for Pseudomonas, use Zosyn, piperacillin, tazobactam, Zosyn. All patients with shortness of breath should receive what? Oxygen, continuous oximetry, chest x-ray, and blood gases. Patient with asthma and respiratory acidosis should be placed in an ICU. Persistent respiratory acidosis is an indication of intubation and mechanical ventilation. Parenteral methylprednisolone, when to use it for patients in the ICU. Let's conclude by the 1% of patients who might get COPD at a young age, less than 40 or 45, and maybe they are non-smoker, search for their alpha-1 antitrypsin deficiency. And the diagnostic testing you see in the chest x-ray bully at lung basis, barrel chest, flat diaphragm, but the blood test is low albumin and high PT and INR. Why? Because these patients also develop liver cirrhosis and their alpha-1 antitrypsin level is low, and you get it by genetic testing, and the treatment is easy. Give them what is deficient, give them alpha-1 antitrypsin infusion.